Good afternoon, everyone. I'm Dr. Youssef Hazimeh. I'm an endocrinologist and geriatrician. I'm American board certified in endocrinology, geriatric, and internal medicine. It's a pleasure for me to be with you today, and I would thank the committee who invited me, especially Dr. Mshaymish, for allowing me to participate with you today about this topic. So I'm going to, I have no disclosure, and we are going to talk about the metabolic complications of bariatric surgery. Especially, I will talk about the metabolic bone disease, hyperparathyroidism, osteoporosis, fracture risk and guidelines. And the next topic will be the hypoglycemia that occurs in post-bariatric surgery patients. I tried my best to collect the recent data, so almost all the data in this mini lecture are collected from the recent literature in the last 5 to 6 years. So bariatric surgery and secondary hyperparathyroidism has been well connected. The deficiencies that happens in vitamin D and calcium after bariatric surgery may lead to elevated parathyroid hormone, which is called secondary hyperparathyroidism. And in this meta-analysis from this month, from January, the meta-analysis took 9 studies containing about 5,500 patients, and they followed them up for about 3.5 years post-bariatric surgery. And at 2 years interval and thereafter, in this specific meta-analysis, they found that patients who have gastric bypass only and not the other procedures, not the sleeve procedure, they found that they have hyperparathyroidism with an odds ratio of 6.0. So that's a significant elevation in hyperparathyroid hormone. Another study from obesity surgery in 2021, secondary hyperparathyroidism, in addition to other comorbidities, were assessed between Roux-en-Y patients and gastric bypass, Roux-en-Y gastric bypass and sleeve gastrectomy. In this series, it's a small study, about 117 patients, with the majority of them are females, age of 41 years on the average, and they followed them for about 4.3 years. And they compared the Roux-en-Y versus sleeve procedure. Secondary hyperparathyroidism was more common in Roux-en-Y gastric bypass versus sleeve gastroplasty, about 18.4% versus 7.8%, despite replacement with calcium and vitamin D. Also, the mean parathyroid hormone level was higher, 61 picogram per milliliter in the Roux-en-Y versus 49 picogram per milliliter in the sleeve gastrectomy. CTX is a marker along the alkaline phosphatase, carboxyl terminal collagen. These are 2 markers that we follow for bone resorption, and both of them were higher in the Roux-en-Y gastric bypass versus the sleeve procedure. And in this study also, they took the bone mineral density, total BMD, and the femur BMD the same. There was a consistent drop in the Roux-en-Y gastric bypass versus the sleeve, and there was an 8% difference in total BMD, and 11.7% in the femur BMD difference between the 2 groups. How about this is another also study comparing the incidence of secondary hyperparathyroidism and comparing multiple other procedures. This is about 1,470 patients. They took patients who had Roux-en-Y, mini gastric bypass, adjustable gastric banding, and sleeve gastrectomy. And in these 4 groups, they compared all of them, and all of them were supplemented with diet, with calcium and vitamin D, and they compared them at 1 and 5 years interval. There was a significant increase in secondary hyperparathyroidism in all the 4 groups. And the highest increase in secondary hyperpara was in the Roux-en-Y patient and in the mini gastric bypass surgery. And also this correlated with a decrease in bone density in all the 4 groups. This is another study. This is a very big study done across the 3 states in the USA, and the data were collected from Virginia, the West Virginia state, New York state, and California. And they did assessed data from 3 different health systems, about 60,000 patients, and they matched 1-to-1 about 26,000 patients, matched to 26,000 patients who had 26,000 with sleeve gastrectomy and 26,000 with gastric bypass. They matched them with the different risk factors, the same number, 1-to-1, diabetes, sex, nicotine dependence, and fracture risk, and their mean age was 45 years of age. So at 3 years after the procedure, they did a comparison between the two groups, the sleeve gastrectomy and the Roux-en-Y, and the rate of vitamin D deficiency was high in both of them, and risk of major osteoporotic fracture was lower in the sleeve gastrectomy, 2.85% versus 3.66% to the Roux-en-Y. The osteoporosis was also lower for the sleeve procedure. Spine fracture was lower, 0.76 versus 1.1. And again, this is comparison between the 2 groups, and they did not compare them to the general population. In addition to the femur fracture, sleeve procedure less than Roux-en-Y. And all of the results were statistically significant. And again, this is, to be fair, this is a study from France. A French team, they found out that gastric bypass, but not sleeve gastrectomy, increases the risk of a major osteoporotic fracture. And this is a French population in which they took about 81,900 patients, and they matched them, they compared them to control group. And in this control group, these are the patients who went for weight loss with medications or diet and exercise. So they matched them, and this is in the national French data. And the types of bariatric surgeries are variable, I'll see in the next slide. And they evaluated the risk of major osteoporotic fractures at the hip, femur, wrist, and distal forearm. And also they evaluated the spine. And in the French population, this team of researchers followed the patients for around 6 years on the average 6 years after the procedure. And what did they find? That comparing to the other group who did not have surgery, there was a significant increase in major osteoporotic fracture in the Roux-en-Y population with a significant p-value of less than 0.001. There was some slight increase in the sleeve gastrectomy, but it was not statistically significant as the p-value was not below 0.05. And in addition to the other methods of bariatric surgeries. So they concluded, this French team, that there was about 585 major osteoporotic fractures in the surgery group versus 416 in the matched group, and it was significantly higher. So if you take all the surgery, there was a hazard ratio of 1.22, which means the surgery raised the risk of major osteoporotic fracture, and the major osteoporotic fracture for gastric bypass only was the highest, and the hazard ratio was 1.7. Their conclusion in this French population that the gastric bypass, but not sleeve gastrectomy, is associated with increased risk of major osteoporotic fracture. And finally, about this topic also, a meta-analysis. This is a meta-analysis, I guess, from Taiwan, but it is they took about 1,000 studies, and they filtered them and took 5 observational trials and 1 randomized trial that they considered of high quality, and they wanted to see the effect of bariatric surgeries on what kind of fractures. So they found that the risk of any fracture was 1.29, and the risk ratio, and the non-vertebral fracture was 1.42, But what they found, and I put this study intentionally, that the highest risk ratio for fracture was in the upper limbs, the upper lower extremity. It was not similar or typical to the osteoporosis fracture that we see routinely when we have patients with osteoporosis. And this is the guidelines from the ACE in 2019. What do the American Association of Clinical Endocrinologists recommend for patients who had bariatric surgery? They recommend multivitamin replacement with mineral. For the gastric band, about 1 tablet. For the sleeve gastrectomy, 2 tablets. And for the Roux-en-Y, 2 tablets. Calcium supplement for all the 3 groups, about 1,200 to 1,500 milligram per day. Vitamin D, around 3,000 units per day, and you should titrate to the good vitamin D level of 30 nanogram per milliliter or more. And a bone density is recommended at 2 years interval after the surgery. It means 2 years after surgery. Now I will talk briefly about the hypoglycemia. In fact, we see this more frequently than we see changes in bone density, maybe because many other doctors take care of the bone density, but we, in general, get referral about patients getting hypoglycemic after bariatric surgery. And post-bariatric surgery hypoglycemia was first documented and described at Mayo Clinic between 1999 and 2000. Many original articles were written at Mayo Clinic about this topic. It is a common complication of bariatric surgery. They described multiple causes, and they found out that hypoglycemia that happens after bariatric surgery starts to happen around 2 years post-op and lasts till up to 9 years. So most of the data 2 to 9 years. In fact, here in Beirut, about 3 months ago, I have seen a patient with post-bariatric hypoglycemia happening 8 years after the surgery. And the frequency of asymptomatic, some of these patients are asymptomatic, and they found out that up to 30% of patients who have post-bariatric surgery hypoglycemia are asymptomatic. The symptoms of post-bariatric hypoglycemia are similar to any hypoglycemic episode that we see in population. And again, I'm not talking about diabetes here. In the general population who have bariatric surgery and they start to have hypoglycemia from the surgery. So any symptoms of hypoglycemia may happen: confusion, disorientation, unconsciousness, syncope, shakiness, tremor, abnormal behavior, anxiety, weakness, blurred vision, and even seizure. And what distinguishes this post-bariatric surgery hypoglycemia from the insulinoma, in general, if you have someone who is having hypoglycemia in the morning, fasting hypoglycemia, you can be 99.99% sure that this is not from the bariatric surgery. Insulinomas can produce hypoglycemia, but the insulin secretion is all day and in the morning, so they get hypoglycemic in the morning as fasting. But if you have someone who is post-bariatric surgery, most of the time, and in general, all the time, it's going to be after meals. And how about the incidence? In this study, they took about 957 patients who had Roux-en-Y, and they enrolled them in a study on longitudinal cohort to see who is going to develop hypoglycemia. And they did oral glucose tolerance test, was performed at 1 year and 5 years. And this, whenever you see oral glucose tolerance test, it's a test performed in USA, and most of the time is by surgery. It's not endorsed by the Endocrine Society. Neither the Endocrine Society, or the ACE, or the anyone who deals with endocrine societies, we don't endorse oral glucose tolerance test. It has complications, and it is not accurate, because many of you here in this hall, if I give you an oral glucose load, you may have hypoglycemia. We call it reactive hypoglycemia, so it's not necessary for post-bariatric. Therefore, but some studies are done, just to put these studies for you. They gave oral glucose tolerance test, and they document the sugar in these patients each 30 minutes, 1 hour, 150 minutes, and so often. And they call it the postprandial hyperinsulinemic hypoglycemia in this study. So it was defined as a blood glucose below 50 and elevated insulin level more than 3 milliunit per liter.
1 minute, please.
Yes. So the incidence was at baseline 0.5, and at 12 months there was 9.1% hypoglycemia, so there was significant elevation, and even at 60 months. And it was associated with lower age and greater weight loss. And this is also another study comparing the Swedish population, comparing Roux-en-Y and other procedures, and they found out that there is an increased risk of hypoglycemia up to 2 to 7 times, and there was some increased hospitalization in the Roux-en-Y, mainly 0.2% of the people were hospitalized. And also a third study, they found, in one of the studies, they found there is no difference between sleeve gastroplasty, gastrectomy, or Roux-en-Y in terms of hypoglycemia. And again, what happens, why do we see hypoglycemia post-bariatric surgery? There were 3 theories. Increased in the beta cell mass. This is a regular pancreas, and this is a pancreas for someone who has Roux-en-Y gastric bypass. They thought there is nesidioblastosis. This is an islet cell, the islet of Langerhans. This is an enlarged islet of Langerhans. This happens in patients during their obesity, so their body might produce more insulin, and this theory is called the nesidioblastosis, or increased in beta cell mass. There was another theory, is increased in the function of the beta cell mass. They found out that these patients, they have increased, even after partial pancreatectomy, you remove part of this beta cell mass, there is an increase in the GLP-1 level and insulin level and C-peptide in these patients. So they found, they put the theory that there is a beta cell function. And there was a third theory related to the ghrelin, which is secreted by the pancreas. And if you remove part of the pancreas, you are reducing the ghrelin, and the ghrelin has some effect on the brain and on the metabolism of sugar. And finally, some use the oral glucose tolerance test, and others in the Endocrine Society and ACE, they recommend to use a mixed meal test if you need it. We here, we don't, most of the time you don't need it as we know it immediately. And the treatment first is dietary modification, diet that can avoid hypoglycemia. Don't eat 3 times per day, 3 meals. Split your meals differently during the day, and use low carb diet, food that has low carb, and so often, and so on. And finally, the medications, medical management, you can use, we have 4 sets of medication. None of them is approved. There is currently a study ongoing in the United States called for a medication which is a GLP-1 receptor antagonist. It works opposite to the GLP-1, to be used specifically for post-bariatric surgery hypoglycemia. So the medications that we used, I had in the state around 15 patients that we were going to do a series on them, who are on alpha-glucosidase inhibitor, اللي بنسميه glucobay بلبنان. This medication works on the GI tract. It inhibits the pancreatic amylase and intestinal brush border glucosidase. This medication reduces the digestion of sugar. Therefore, the sugar will not be absorbed quickly into the blood, and there is no spike in the insulin, and this works very well. Somatostatin analog, we had in my practice in USA also 1 patient on octreotide. Insulin anti-diazoxide, which is a medication that helps to decrease insulin secretion, and calcium channel blockers like verapamil has been shown in certain case reports that they reduce insulin. And this is the last slide. This is a case of 1 patient who had severe post-bariatric surgery hypoglycemia, and he used to have multiple, 75% of his post-dinner time, he will have hypoglycemia. They tried him on multiple medication, acarbose, octreotide, lanreotide, octreotide, and diazoxide. So they tried a different regimen. This is just a case report, and one of the regimen helped here to reduce his hypoglycemic incidence to 10% instead of 75%, which was the octreotide with diazoxide. Thank you. Thank you. Thank you.